So morning everyone, and thanks for the opportunity to present at this wonderful meeting. I'm going to talk to you about catastrophic costs at the patient level, also talk a bit more about social determinants and ways in which we can address social determinants and what that might mean for modellers. In terms of thinking about social determinants, I just had to share one that I thought was fantastic that I found from 80 years ago, that too much dancing brings TB. Recent scientific investigations have proved that dancing must bear a part of the responsibility for the increase of TB among young people. So if you're thinking about it on Friday, throwing some shapes on the dance floor, think again. Looking more at TB costs, we've known and we've seen in the presentations before that TB costs through the journey of the patient, from recognition of their own illness to health-seeking behaviour to diagnosis to treatment and beyond, are high. And those can be direct costs, which are things like medical costs such as medicines or clinics, or non-medical costs like food or travel. And more recently, I think we've come to realise that the time costs and the loss of income are actually extremely important costs, and I'll come back to that later. On the right-hand side of this figure as well, it shows the coping strategies that people have to adopt. And these can be proxy measures of costs, such as, for example, taking a child out of school, taking out a loan, using your savings, having to sell household assets. And these are very important. And over the last 10, 20 years, there have been various attempts made at looking at patient costs. And this is, for example, a USA tool that's over a decade old that took into account all of those factors that I was telling you in the last slide. And so data came in, and Knut and his team in 2014 looked at data and costs across different countries and essentially found that the cost burden is high. But interestingly, that a third of the costs are due to lost income for TB patients, and 50% of the costs have already happened prior to taking that first tablet. And I think this is where the issue about social protection comes to the fore. So I was lucky enough to work with the Innovation for Health and Development team headed by Carlton Evans out in Peru. And we tried to define catastrophic costs a few years ago now, not just financially, but also clinically. What did they mean in terms of adverse outcomes, so death, treatment failure, treatment abandonment amongst patients? And so in this, in Ventanilla, which is just north of Lima, the tireless nurses which we work with followed patients up every month throughout treatment, doing cost surveys essentially every month throughout treatment. And we found that if you added up all of the costs of the patient, if they were above 20% of the household's annual income, these were catastrophic. And what do I mean in terms of catastrophic? Well, actually, you had a twofold likelihood of having an adverse TB treatment outcome, so dying, treatment failure, treatment abandonment, if you incurred catastrophic costs above that threshold. 40% of our cohort incurred catastrophic costs. So when you compare this to MDR-TB, about 10% of our population had MDR-TB. As Dick Menzies was mentioning yesterday, obviously looking at odds ratios or relative risks, there's a much higher risk with MDR-TB of having an adverse outcome. But when you looked at the population attributable fraction, so if you were to remove that risk factor, how much adverse treatment outcome could you eliminate? You can see there that actually by removing catastrophic costs or removing MDR-TB, the amount that you'd eliminate adverse TB treatment outcome is actually quite similar. The other thing that we noted is these are thresholds on the x-axis, 10% of annual household income, 20, 30, 40, and along the y-axis is the adverse outcome again, that you had a great heterogeneity in these costs, and you can see people over to the right there who are incurring above 70% of their annual household income had about a 1 in 2 chance of having an adverse outcome. Obviously, those numbers were low in terms of the absolute numbers, but a general rule was that the poorer households were more likely to incur higher proportions of their annual household income, showing the medical poverty trap. So in the NTB strategy, as we all know, there is the bold goal to eliminate catastrophic costs, but also to provide socioeconomic support. And the provision of socioeconomic support was not very well defined. The handbook that I was lucky enough to work with Andrew and the team on is now being produced, and as you've seen from Brian's slides and others, it's been implemented in about 15 countries now, and a lot of the data is now coming through about these costs. But once we've identified these costs and social determinants, what can we actually do about them? And I just come back to Dick Menzies' talk yesterday. So this book called by Robert Tressel called The Ragged Trousered Philanthropist, this was published the same year in 1912 as the Papworth experiment. And this was a book about the working classes and poverty in England that is really worth a read. And in it, he says he visits one of his colleagues' houses who's living in poverty and squalor, and says those who profess to be desirous of preventing and curing consumption must be either hypocrites or fools, for they ridicule the suggestion that it is necessary first to cure and prevent the poverty that compels badly clothed and half-starved human beings to sleep in such dens as this. So this is a century ago, and it was recognised. So we took inspiration from this, working with the team in Peru, and we did this household randomised evaluation of a socioeconomic intervention to prevent TB, which is the acronym RECIPT, which I think sounds a bit like producing a sample. So what is RECIPT? Well, in terms of goals and outputs, we wanted to find TB. How do we do that? Well, we screened contacts for TB infection and disease, household contacts. We wanted to prevent TB, so contacts had to start preventive therapy if they had infection. We wanted to cure TB, and so patients with TB had to adhere to treatment and complete treatment. And the overall goal of the ongoing study, which is a community randomised study, is to control TB. But in this study, we randomised about 300 households to receive socioeconomic support. So 150 received socioeconomic support. What do I mean by that? Social support was household visits, which were educational, and community meetings. And those were really to educate, inform, and for reduction of stigma for those households. For completing all the things in the green boxes, then households were given economic support. So this was throughout treatment, and it was conditional cash transfers into bank accounts. And that added up to about a maximum of $230, which was about 10% of the household's annual income in that setting. So what did this mean in terms of our primary outcome, which was initiation of TB preventive therapy? The dark bar on the left is the contacts from intervention households, who had 44% of whom started preventive therapy versus 26% in the control arm. In terms of TB treatment success, 76% on the left had TB treatment success in the intervention arm of patients versus control households who had 63%. But I just wanted to point out that there was a lot of heterogeneity in terms of the treatment success. So this is just the intervention households, and this is how much they engaged in the intervention. So the left bar is everything. They engaged with everything that was offered. The middle bar is they engaged with some of the activities, and the far bar on the right is those who engaged with no activities. And so you can see there's a great difference in their TB treatment success depending on how well our intervention reached that group. Coming back to costs, what did our intervention do for catastrophic costs? Well, you can see there the white bar on the left, or the grey bar, shows 42% of the control households incurred catastrophic costs at this 20% or more threshold of annual income. And yes, we did reduce catastrophic costs in the intervention arms, but only to 30%. So still a third of households, despite us putting in all this effort, was still incurring catastrophic costs. So I've been working with the Sparks Network, which is an international collaboration based at Karolinska of people interested in social protection to try and adapt this intervention for different settings. For example, settings with high HIV burden, like Mozambique, or settings that don't have commonly cash transfers, for example, some parts of Nepal. And I'm hoping to do that in the Beyond TB trial. But what about wider evidence for things like cash transfers focused on TB-affected households? There's not that much wider evidence about them. Recently, in I think May of this year, this was a systematic review of cash transfers, which included our trial, which showed that treatment success was about 1.7 in terms of odds ratio in those patients who received cash transfers. And I'm sorry, this is a slightly busy slide, but it just shows that combined interventions, so psycho-emotional interventions, so counselling, combined interventions like social and economic support, led to some increase in treatment success, but again, not quite as strong as the last slide that I showed. What about TB-sensitive interventions? So this is intervention not aimed at TB-affected households, but, for example, aimed at people who are living in poverty. they may also have a place for improving TB prevention, as I think, or TB outcomes, as I think we've seen in some of the earlier slides. And so Andrew built on some work by Aaron Reeves from Europe, but he did a global analysis looking at the proportion of a country's GDP that it's spent on social protection, and that's on the x-axis, and then on the y-axis is TB incidence, and you can see that there's a clear association there, and also with mortality. And obviously this doesn't infer causality, but it's an interesting association. And talking to colleagues last night about Brazil, so Brazil's Bolsa Familia is a poverty reduction program that gives cash transfers to households when a child in their household or children engage with school and have their immunisations. And this is the biggest cash transfer system on the planet, 12 million households covered. And so people have looked at the data, which thankfully is very well recorded, on what that meant for TB-affected households who were eligible to receive a cash transfer and did, or eligible to receive a cash transfer and did not. And they've shown that treatment success in the patient households who did receive Bolsa Familia, the odds ratio is 1.07. So you might say, well, that's a tiny, tiny increase. But if you had a drug that improved by 7% your likelihood of treatment success, I think that drug might be rolled out. And what about incidence of TB? Well, the areas of Brazil that had better coverage with social protection through Bolsa Familia when adjusting for other factors seem to have a slightly lower incidence of TB. But again, these are quite weak associations. So coming now to what surprised me about the invite and what I've tried to get my head around is cost considerations for modellers. So something with all the data that's going to come back from these cost surveys is there are still wide differences in what people are doing in terms of what they're reporting as catastrophic costs. So different thresholds of annual income, 5, 10, 20%, even though it is set out in the survey what the threshold is. Obviously, you should probably try to use more than one threshold as your sensitivity analyses. And also people have been still using, as is right, 40% of capacity to pay, which is what a household has left after meeting its subsistence needs. So I think just to be aware of those different definitions. Lost income, as I've told you, I think is really important. If you look at an output approach, so you say to a patient, what were you paid before TB and what are you paid now, versus the human capital approach, which is how many hours of work have you lost and what was hourly pay? You find there are great differences between those two estimates of lost income, with the human capital approach often being much higher lost income. So I think both of those should be presented and should be transparent in findings of the catastrophic cost survey, but they're very important in terms of how different they are. The extrapolation of costs, I think, is important. As I said, in Peru, we follow people up for one month throughout treatment, but most of the cost surveys are just doing one cross-sectional visit, and within the cohort, there's some bootstrapping and extrapolation to try and understand the cost throughout the course of treatment. So I think the better data would be from repeated visits, but clearly that's not feasible for many programs. We've talked a lot, I think, about subgroups and heterogeneity. So, for example, HIV and TB co-infection, diabetes. We know that multi-drug resistant TB, people affected by that have higher costs. But I think there's also an important issue, especially, for example, in East Asia, about the public-private mix. And we might not be getting the data available for those people who visit private and public clinics as well. I think, as shown by Andrew's work, I think we need to recognise the health and social care structure within which we work. For example, if a country is introducing more sickness or disability allowance or increasing its coverage, or if it is dropping charges for medicines, those things obviously need to be incorporated into a model. And I think, as has been mentioned, I won't talk about it much, is that we don't really know the impact on TB transmission of costs. We know a bit more about TB outcomes, perhaps, but I don't think we know much about transmission or prevention yet. And as has been mentioned in the discussions earlier, I think the causal pathways are quite unclear in terms of the weight of different things: malnutrition, assortative mixing, chronic stress, alcoholism, related to costs. I don't think we know the weight of each of those variables, and I think that's something that's largely unexplored. So just to come to my last couple of slides, so David, who obviously sadly can't be here, and Ted came up with this tuberculosis modeller's wish list. So I've just slightly adapted this to a tuberculosis trialist wish list as someone who does socioeconomic interventions. So, and this is coming from somebody who doesn't know a lot about modelling, so apologies. But clarity and transparency of the model methods for the uninitiated, that's why I really liked the article from you and David. I could understand it about all your needs as modellers. Early and sustained collaboration like this, I think from a design stage, we need to be collaborating, and not just trials, but implementation research, and also how we can capacity build with national TB programs about how to collect the data that would be most useful. Funding applications. If we're doing multi-arm, multi-stage studies where you have 8 arms and you drop a few of those arms depending on output, I think that there's a real place for modelling in deciding which of those arms that we could drop. And translation to policy, I think we've talked about. Very last couple of things. Data requirements for modellers. When I go into the field with the team, I need to know what's your ideal and what's feasible in terms of data collection. I think we could find a happy medium, a sweet point. And so I'd need to know what's your priority in terms of top variables versus those that you think are less important in your model. And we've talked about the different levels of modelling. Accounting for heterogeneity as well, so we can support targeted interventions. I've shown you that our intervention worked well for some and poorly for others, especially those who are extremely poor. And as Stefan has talked about, or will talk about, extended cost-effectiveness analysis. If you can say to a policymaker, well, actually, it had a moderate effect on TB prevention, but in terms of SDGs, it reduced poverty, it reduced child malnutrition, it reduced childhood diarrheal disease. I think that those wider effects actually might be listening to those a lot more than just a TB-specific focus. And so that's the wider implications on health and well-being. So thank you for listening.
Thanks, Tom. Questions, Anna, and then Stefan.
Okay, thank you. That was a wonderful overview. I have sort of 2 sets of questions. I mean, the first one, you very nicely looked at sort of social protection and cash transfers, and I'd actually like to say there's 2 choices with cash transfers, one conditional and one non-conditional cash transfers. And I think the sort of discussion is the sort of policy choice that we're trying to inform is not so much do they impact on TB, but actually which one of those 3 is the best way of delivering social protection for TB patients, and that's likely to vary a lot by setting. So I'd like to sort of hear your views on that from looking at across all these different types, when do you think one should do additional work on the TB side? Because I think that's the question we're trying to answer. I think a lot of economists and people who work in social protection really sort of react against sort of disease-specific intervention on the income side. So I think we need to make a strong justification as to why that would really be necessary. So I'm interested in your views on that. The other sort of questions I have are really about the methods. And it's quite interesting using the WHO methods, but applying them to trials. I mean, I think those costing methods are for different purposes in some ways, though you're completely right to say, well, what's most interesting to collect on the trial basis? I mean, you mentioned the difference with the thresholds. I think one of the issues is the threshold that came out of your study, the 20%, which is great, but it actually isn't a threshold of catastrophe.
Agree.
And it's been criticised sort of very heavily on that grounds. And I do think we're in dangerous ground from the rest of the economic community when we're using even though that is... So I think that's why we have this problem. I think the other issue, which, again, I think is very different when you're doing national surveys versus really trying to understand what's happening, is whether you collect data at the facility or the household level. So you had your other sort of areas of sort of challenges, but I think one of the issues is that we know we get very poor data collection from interviewing people at facilities about household income. So whatever method we use, any of those 3 methods, we know we're getting it wrong. And I think that is a challenge, and maybe on a smaller scale, when you're looking at trials or interventions, you have the opportunity to measure costs at the household level, whereas clearly the WHO doesn't have that opportunity. So I'm interested to hear what you think about that.
Okay, so the first question, in terms of conditional versus unconditional, just as an example, in the wider community randomised study that we're still running now and Carlton is running in Peru, we've actually changed to unconditional cash transfers. And the reason for that is, I think conditional cash transfers actually don't work for the most vulnerable people. And so I think in terms of equity, I think unconditional cash transfers work much better. And we give those at the beginning of the month rather than at the end of the month. We still ask people, these are the conditions, but they don't have to necessarily be fulfilled to receive the cash transfer. The cash transfer will come anyway. So I agree that that's whether you use hard conditionality or soft conditionality or unconditionality. To me, I think we should be using unconditional cash transfers. The second question, I completely agree with you. I think, to be honest with you, I think to have an indicator, I think, needs a threshold. I think the most important thing is that we're measuring costs. And I agree with you completely, whether it's 10, 20, 30, what have you, that's going to vary across countries. It's not going to be useful for some, it's going to be useful for others. But I don't think we've found a good proxy measure yet. And I think the proxies that we use, for example, we talk about dissaving or selling of assets, are so different in each specific setting that I think these are going to need to be adapted in each country. And I think you've done so much work in that already, but I think we're only getting there on a kind of maybe a national level. The third question was...
Maybe the household versus facility.
Yeah, so most programs now recommend a household visit. But admittedly, you need to spend 60 to 90 minutes at the household to do a cost survey. If we could find a few simple questions that really, for example, we did principal component analysis on some of the data we got to try and boil down the few key questions within the data that we're getting from the however many questions we've got in the survey, that might be the most important thing for the future. But again, I think that will be country specific.